So, changing behavior is a very challenging thing to do. And when you work in mental health as a clinician or a doctor, that's kind of your business. That's the goal. Usually, if someone comes into the room of a psychiatrist or they're seeing a psychologist, there's usually a problematic behavior. Um, if someone's been violent or using drugs or not taking their medications and becoming unwell, and for whatever reason ending up in the emergency department or getting admitted to a mental health ward, usually you can trace it back to some problematic behaviors. And it's a big part of our work is motivational interviewing and trying to support people to generate their own insight into not that their behaviors are bad, but that they need to change. And I've had some interesting discussions this week around motivational interviewing. Got me thinking, realized hadn't really talked about it much on this channel. And so thought we should talk a bit about my approach, but also wanting to read through the comments to hear your approach to how to support people in behavior change. I think a good place to start is to reflect on how good are we at it. And I haven't done a literature review for this video, but from med school, I remember hearing that the medication compliance rates in the community from a GP population is about 50%. And that was echoed this week as well. So I think it's about half of the people who are prescribed medications take them as prescribed, roughly. I'm sure there's very wide variability depending on different places and different illnesses. But whatever the case, in the psychiatric population, it's probably lower. Maybe not for people who have, depression, anxiety, who finding benefit from their medications, but certainly people who have substance use or a psychosis or a bipolar illness or who have medications with negative side effects. We have much lower rates of compliance, and it's a major cause in people's relapse of chronic illnesses. So, if we were good at supporting good behavior, quote unquote, then we would have 100% compliance, but we're not. So if we take the example of substance use, drug use, and we think about someone who's using a substance and we want them to change that behavior because it's causing problems. So for example, they've been admitted back into hospital with a drug-induced psychosis, or they've committed a crime that's related to substance use, stealing money, breaking and entering, that kind of stuff. And we're trying to motivate someone to quit. Why don't we reflect on what typically happens, and then we can think a little bit about what is more effective. So what typically happens whenever you're trying to, and I remember as a intern and resident getting into these fights, when you're trying to assess why someone is doing their behaviors, you kind of look for the reasons why they're doing it and the reasons why they're not doing it. And when you ask them, like, how do you feel about drug use? Is it something you want to change? Often they've had this conversation a lot of times, and it's often with their parents or with caregivers or authority figures, and it's been a very similar conversation every time where they've received a list of reasons why their behavior is bad, and they basically just leave feeling like they're not understood, like they, like, screw you, you don't get it, you don't understand why I'm doing it, and it just creates a big divide when you have someone who doesn't have a substance use disorder, who, apparently, at least in the review or in the relationship, looks like their life is on track, talking to someone who's struggling with substance use and telling them why it's bad. I guess the first thing to know is they know why it's bad. Most people who use substances, whatever the substance is, they can tell you why methamphetamine isn't healthy, and why it's not great. And they recognize often that there's it's an addiction, it's a compulsion, it's a need. It's not a healthy need, but they don't care about health. That's not their priority. The priority is to get the drug. And so if you are in a review with someone who is open to talking about their substance use, and you're presented with an opportunity for motivational interviewing, and you go down this route of saying, well, methamphetamine is very addictive, very hard to stop, causes brain damage, terrible for your teeth, terrible for your health. You can get a lot of problems with methamphetamine use. They're just, they're going to leave that review having no change in their behavior and feeling like and having a worse experience of healthcare than before. So I think we need to change our approach and not get caught into this telling people why it's bad, unless they're asking and they're genuinely curious, and in which case it's a different dynamic. So what do we need to start this conversation to change a behavior? Before making this video, I was having a think with my cup of coffee before my cup of tea. I think you essentially need three things. The first, and I'll break them down. So the first is rapport with the person. The second is they have to be at a just between pre-contemplative to contemplative. That's if they're, and I'll explain what all this means. But if they're if they're almost contemplative or they are contemplative, that is where there's a lot of value. And the third thing is they need to be sober, which can be very challenging with people with chronic substance use issues. And that's not an absolute, but it's certainly helpful. So if we look at the third one first, actually, being intoxicated, because that's the most simplest. Look, doing motivational interviewing with someone who's intoxicated is just not an effective use of anyone's time. Often they will forget the conversation. They're just not in a brain state to engage and remember and recall the insights that are generated in the conversation. And I've had conversations with people who are intoxicated around stopping alcohol and felt that we had incredible insights generated, and then they forget the conversation the next day. So probably wasted a bit of time there. It's probably best just if someone's intoxicated, get them to agree to having a conversation, sober them up, get them stabilized, whatever the scenario is, get them sober, and then have the conversation once they've had a bit of rest. Now, the first thing I said was rapport. Yeah, rapport. So what is rapport? Rapport is it's more than just having a good relationship with someone. It's essentially empathy reciprocated is the way that it's been described to me that I really like. So it's you sitting down with someone and being able to put yourself in their shoes, being able to really empathize with what they're kind of going through and what their ways of thinking and behaving are, but then also them having the ability to sit in your shoes and understand why you're talking to them as well. And that's the part that is often forgotten, but it's really important in a functional therapeutic rapport, whether it's a parent to a child or a doctor to a patient or a counselor to a client, whatever the dynamic, that both people understand why both people are there. Now, sometimes a patient can't understand what you're doing there, or they don't care, or they just want to leave and go score, or they don't want to engage in a conversation. And that's a difficult situation, but motivational interviewing might not be the right intervention at that time for that person. But if you can get a rapport, a connection, a therapeutic alliance with someone, they will feel safe in exploring what they obviously, or what has been perceived as bad behavior, right? Whenever you're told to change something you're doing, the immediate reaction for everyone, I shouldn't make generalizations, but for a lot of people is shame. And the next step in shame to defend oneself is usually anger or avoidance or both. So, you're doing drugs, it's bad, you got to stop. My first response is I'm getting attacked. Like, I'm starting to feel ashamed. Who the hell do you think you are attacking me? Get the hell out of my face. I'm not listening to you. so that kind of approach isn't going to generate effective behavior change. But if you can form a rapport, a connection with someone, and they can see that you're not trying to be bigger than them or better than them, or it's a competition, but that you genuinely care, uh, then there, then there's more trust to explore shameful topics. And there are many ways to, many things you can do to support the rapport between, just to create an effective rapport between two people. Sitting at eye level, talking at in simple terms, not belittling, not using the word "but" too much, uh, and validating are all effective things. An interesting study in emergency departments showed that when doctors came to see patients and they saw the patients for 3 minutes, if the doctor was standing, the patient would perceive the time spent together as about 1 minute. And if they sat down with the patient, but they still only spent 3 minutes, it would be perceived as 9 to 10 minutes. So, the patients feel more connected with based on the behaviors that doctors are displaying. And I always try to sit for reviews. And I also try not to, you really don't want to make anyone feel ashamed of their behaviors, because once there's shame, it's all blocked off and you're not going to get anywhere. So that's the first thing, creating a rapport. The second thing around being pre-contemplative or contemplative. Look, there are these things called the stages of change. And if I guess the reason I bring this second point up is because if someone is using drugs and doesn't want to stop, and is so far from considering stopping, then you're not probably going to be able to change their mind. Sadly, I'm sure there's exceptions, but usually it requires the individual to realize that, maybe this has got to stop, or they need to at least have like a nudge, an internal drive, even if it's a small nudge into the right direction. And so they just need to like either be between pre-contemplative and contemplative. So starting to think about the heart, like starting to think about this has got to stop. Or they're contemplative and they're still using, but they're saying, this has got to stop. Like, what do I do? And really the goal is we're trying to shift people into the contemplative area of their problematic behaviors. Now, I know this video is using drug use as the behavior, but it could be anything. It could be using medications. It could be going to work or going to school. So I think drug use is just the easiest example to talk about, not necessarily the easiest example to act on. Okay, so now you've met those prerequisites and you're ready to get into this discussion, this conversation around why one should change. And the biggest trap to fall into is to go into why the behavior is hurting them or others and why it's harmful. Because either they know it, or B, that's what everyone's been doing and it hasn't worked, and you're going to just fit the mold of the authority figure that's telling me what to do that doesn't understand me. The more effective approach is to spend time trying to understand why they are doing the problematic behavior. So a common question I ask is, how are drugs helping you? Right? How do they help? What are you treating? Is it the pain of grief that you have when you're sober that you're trying to avoid? So they're used as a defense mechanism where you're avoiding pain. Is it having fun with friends and feeling like you can only be with these people if you're using drugs, and if when you're alone you feel isolated? Is it, whatever the reasons, you really want to try and explore why they use it, and then it's all about trying to have them generate the insight, right? So it's about putting the ball in their court, and sometimes that requires a bit of paradoxical intervention or reverse psychology. So usually I'd start by saying, and how is it helping? Explore that. And is it something you've thought about reducing or changing? Is it causing any harm, or is it problematic in any way for you? And trying to explore what they feel are the harms associated with the drug use or problematic behavior. And when they explore their pros and cons from their perspective, not you telling them what's bad, but them generating it themselves, then you can try and um, kind of, well, use their reasoning and feed it back to them, right? So you're saying you want to keep drinking because the pain of being sober is too much and you can't handle that pain, um, and that now's not the right time to stop drinking. Okay. And then you just sit in silence. You're just putting it back to them, and sometimes you say, it sounds like, based on what you're saying, that now is not the right time to stop drinking. Silence. Use silence. Insight is generated in silence between words. Just shut up. I say that because I need to use silence more effectively, but it's a very important tool. And so you're putting it into their, into their court. So okay, they don't want to stop drinking. Then you sit with that and you say, okay, if ever that, and after the period of silence, so two things can happen in that silence. Either they go, oh, I wasn't expecting you to agree with me. I thought you were going to tell me that I should change. And then you can use that. You can say, look, I cannot control you. Your behaviors are your own, and I can support you in the decisions and just give you the information you wish to know. If you are interested in knowing my views on what would be the better decision, I can tell you the side effects of the drugs, the benefits of stopping, how you could stop, what that would be like, the different services involved. But that's only if you're ready. If you're not ready, then you can always come back later. Again, back in their court, they're having to generate the drive themselves. An unfortunate part of this, especially if you're a parent to a child as opposed to a clinician to a patient, is that there has to be a tolerance, especially if you're working in the clinical dynamic, that the person can make illogical decisions. That's quite different if you're a parent taking care of a child and there's a dangerous behavior and sometimes you have to be more authoritative. But in the dynamic of the clinical dynamic, then it's about understanding that some people aren't ready to change, that it isn't your job to control what people do, and that you will have a more positive effect on them and their behaviors if you can leave them feeling like you're there for them when they're ready, and that you're not just going to be another authority figure making them feel like crap. All right, I might leave the video there. That was just some reflections I wanted to discuss. It's by no means a 100% success rate, and really motivational interview is just about asking questions and getting people to think. It's about them generating their own insights and not you imposing your views on them. And so I hope that this has given you some food for thought for your interactions coming up. The one thing you want to be careful about with paradoxical interventions is if it's a dangerous behavior like suicide. So if someone's saying, I want to end my life, you don't want to say, well, maybe it is the right time to end your life. Obviously, that would be, enabling. So it's a little bit nuanced. So thank you very much for watching this week's video, and please comment down below any stories you have to share about any successful kind of behavior change you've been able to generate through this kind of motivational or insight generating discussions. And I really look forward to reading them. All right, cool. Bye for now.